Respected chairpersons, esteemed audience, my topic today is newer anti-tubercular drugs. I would like to start by the quote of this gentleman, Jim Yong Kim, who was the 12th president of World Bank from 2012 to 2019. He said that if you look at three diseases, the three major killer diseases, HIV, tuberculosis, and malaria, the only disease for which we have really good drugs is HIV. And it's very simple because there's a huge market in the United States and Europe. That's why newer drugs in tuberculosis is few and far between. Practically, you will be surprised to know that one of the newer drugs, bedaquiline, came into the market almost 50 years after discovery of rifampicin. Now, India developed a strategic plan to eliminate tuberculosis by 2025, and that necessitated a paradigm shift in approach and management of tuberculosis. But DR-TB, drug-resistant tuberculosis, became a major impediment in achieving that goal. Now why? What is the necessity of developing newer drugs? Because of the figures you see there on the screen. 50% of all cases all over the world, 50% of DR tuberculosis is from India. Number of DR tuberculosis cases from 2007 to 2017 is more than 14 lakhs. And out of those, 20% cases are newly diagnosed tuberculosis. Now, before going to the drugs proper, let's have a quick recapitulation of what are the types of resistance in tuberculosis. Where it is resistant to a single drug, this is monoresistant, but for us, this is important that MDR tuberculosis, when tuberculosis, tubercle bacilli is resistant to both rifampicin and INH. And XDR is resistance to, in addition to MDR, it is resistant to one of the fluoroquinolones and one of the second-line injectables. But please keep in mind that isolated rifampicin resistance is very, very rare. Rifampicin resistance is almost always associated with INH resistance. That's why rifampicin resistance means or almost equivalent to MDR tuberculosis. Now, how do you diagnose resistance? There are two diagnostic modalities, that is CBNAT, cartridge-based nucleic acid amplification test, and another is LPA. Now, by CBNAT, diagnosis is confirmed by 2 hours. It takes care of both pulmonary and extrapulmonary specimen, and it identifies only rifampicin resistance, whereas LPA detects both rifampicin and other FQs and SLIDs, but it takes 72 hours for result. And now the drugs proper. If you look, there is a new classification, newer drugs in tuberculosis. The first group is fluoroquinolones, second is second-line injectables, third is other agents, and D is D1, D2, D3. I will touch upon the drugs in short and tell you in a bit detail about this bedaquiline. Now the first group, that fluoroquinolones. Fluorine atom is attached to the quinolone atom, and it prevents bacterial DNA by unwinding and duplication of the DNA. It is important side effect is tendinitis after a prolonged use or even tendon rupture, particularly in diabetes mellitus patient. And with long-term use, fluoroquinolones may lead to diarrhea. And it is almost mandatory that if a patient suffers from long-standing diarrhea with fluoroquinolone, please don't forget to send a stool sample for pus cells and blood, because then you are sure that you are probably dealing with a deadly condition known as pseudomembranous colitis. Second-line injectables, there are only 2 side effects important, that is ototoxicity and nephrotoxicity. Linezolid, that is oxazolidinediones, 100% oral bioavailability. almost equal to or equivalent to that of intravenous injections. The unique feature of this drug is it inhibits protein synthesis at the very fast stage, that is at initiation. It leads to pancytopenia and peripheral neuropathy. Whenever their peripheral neuropathy develops in patients who are with antituberculous drugs, please keep it in mind that linezolid may lead to often irreversible peripheral neuropathy that may not improve with even increasing the dose of pyridoxine. Cycloserine may lead to depression and suicidal ideation, and that's why patients may need long-term antipsychotic drug treatment. Ethionamide may lead to gynecomastia and peripheral neuropathy. And clofazimine that may cause hyperpigmentation in ichthyosis. Now come to this betaquilin that is made accessible in India in 2016. It is a diaryl quinoline mainly metabolized in the liver. It disrupts mycobacterial ATP synthesis, that's why it cuts off the energy supply to mycobacteria. It has extensive tissue distribution and its extended half-life. That's why you may found it in the plasma even after 5.5 months of stoppage of therapy. But please keep in mind that it should never be given as a single drug. It should always be given with optimized background regimen. And before starting betaquilin therapy, you have to assess levels of calcium, potassium, and magnesium. Dose is 400 milligram once daily for 2 weeks, then 200 milligram thrice daily for 22 weeks. And some of the drugs should never be used during therapy of betaquilin, that is azoles, statins, phenytoin, carbamazepine, and rifamycins. And these are the indications of betaquilin with tuberculosis. It should never be given with a failing regimen. And this is important again, if a patient is under betaquilin therapy, ECG should be monitored regularly because it may prolong QT interval, and in spite of that, if you continue, patient develops torsade. So it should be stopped if QRR interval exceeds 500 milliseconds. Delamanid is not used in India now, and some points about hepatotoxicity. Almost all antituberculous drugs, they are hepatotoxic. And that's why if it is SGPT or ALT is less than 3 times of normal, you can continue with the drug. If it's more than 3 times, but less than 5 times of normal, then decrease the dose, and more than 5 times, stop the drug. And there is, this is the RNTCP guided regimen, and this is RNTCP guided regimen for XDR. Because of paucity of time, it is difficult to continue with this drug. There is no need. And so I would like to conclude by a take-home message that just remind that I had a sumptuous lunch, Sunday lunch today. But please don't forget tuberculosis, because tuberculosis is going to shoot humanity on the forehead. Thank you.